Good day. This is Charles Denham. I am chairman of TMIT, and welcome to our fourth part of a fourth-part series in engaging and partnering with many stakeholders across the healthcare value chain. Today's webinar is engaging and activating and partnering with suppliers as performance partners. It is part 4, and I would like to welcome all of you. There are just a couple of quick items. If you're on the WebEx, just to make sure to request a phone line if you're having difficulties, and make sure that your audio is up as high as possible. Because our CMS leaders have to depart very quickly after their session, we'll ask Reggie Holiday today to give us just a brief set of inspirational comments as the voice of the patient. She'll be a speaker later. And so, Reggie, your quick message so we can let our CMS leaders take the helm.
I was just really excited to be part of the call today and present the patient voice as a wife, a mother, a caregiver, and artist, and how as we participate in the dialogue with people who work in government, health professionals, and health information technology, working together we can all create amazing change. So it's so exciting to be part of the call today.
Thank you, Reggie, and Reggie will be speaking a little bit later. Our disclosure statement is very much modified from that is typical. We will be talking about products today. Presume conflict of interest all the way through the entire presentation, because we have to address products, services, and technologies and partnering with providers. And a major part of our discussion is how to overcome the distrust and conflicts of interest that are embedded in those. We have further disclosure statements, and I'll just advance the slides to Dr. Paul McGann and Dennis Wagner, the two acting directors of the major divisions of the Centers for Medicare and Medicaid, who have now assumed deputy positions now that we have a new chief medical officer. However, Dr. Paul McGann served wonderfully as the acting chief medical officer, and he's now the deputy chief medical officer. And Dennis Wagner is the deputy responsible for the clinical standards and quality. Paul and Dennis, please take it away. And I will mention that they have just been evacuated out of CMS and are doing this webinar remotely by a distant phone, and we thank you for doing so in the middle of a crisis there at CMS.
Very good. Thank you, Dr. Denham. We're absolutely delighted to be able to be on this call. Good morning and good afternoon to everyone. It's terrific to be on this call with Dr. Denham, with Joe McCannon, with Reggie Holiday, the patient representative, and the other members of this webinar. I'm going to quickly ask to look at the very first slide of our presentation, which is titled the Affordable Care Act. And although Paul and I were originally slated to discuss teaming for high performance, we wanted to actually give sort of a gestalt, big picture view on the Affordable Care Act. These is brand new material that we have vetted very recently with the senior leadership team here at the Centers for Medicare and Medicaid Services. And it's really a big picture view, if you will, of the Affordable Care Act and all the changes that are coming with the health system. New tools, new incentives, new disincentives, new programs, and even new organizational structures around things like medical homes and ACOs. And we wanted to take our 10 minutes and really just share with you what that big picture looks like, not just from the perspective of CMS, but I think from the perspective of the supplier and the provider and patient communities. If I could turn to the second slide, I would just acknowledge that with all these new things, tools, incentives, penalties, programs, and structures, that I think a fair number of people in the healthcare sector are feeling what I would call overwhelm. And I would say that's true here at CMS at some level when we're implementing these rules, one after another, trying to meet statutory deadlines and things of that sort. But I think it's probably even more so feelings of overwhelm with the provider and supplier communities. And there's sort of these two questions, what's all this mean and how do these pieces fit together to kind of keep that straight? And so we're going to share with you a perspective on that I think is encouraging and perhaps even enlightening in terms of how to manage those feelings and how to participate in the development, the very exciting development of the new system. I'd ask you to turn to the third slide and would just say right up front that the work we're doing now, I think more than ever, really places patients at the center of the healthcare system. And I'm so happy that Reggie Holiday is on the phone, because I think her presence on this on this webinar, and the inclusion of patients with information and transparency and a focus on their quality. That's really what a lot of this work is all about. We want better care, better health, and lower costs for those patients. And I think that three-part aim, that mantra, is very familiar to anyone that's worked with Don Berwick, and increasingly those who have worked with CMS over the course of the last year. So with that quick intro, I'm going to now ask us to turn to the fourth slide and turn this over to my colleague and partner, Deputy Chief Medical Officer Paul McGann. Dr. McGann?
Thanks very much, Dennis, and thank all of you for joining us, especially Reggie. We learned really at CMS only recently how powerful the voice of the patient is, and we're just so happy that Reggie and others like her who have really transformed their personal tragedies into help for millions of people are continuing to be dedicated to this and join us in our effort. Now, what I'm about to do now, we only have a total of about 8 or 10 slides, and just hold on to your seatbelts now, because we're going to now start with that simple patient-centered diagram that Mr. Wagner just showed you, and we're going to ride for the next 5 slides up that ladder of complexity, which causes that feeling of overwhelm. But I promise you, just like a good symphony, by the end of this talk, we're going to have a nice, simple resolution that we hope is going to help you understand all of the bewildering changes that are coming not only out of the Affordable Care Act, but also erupting spontaneously from the private sector as well. So next slide, Chuck, is the one with a dark blue circle that puts and layers on this atomic structure of complexity, the provider circle. Now, we don't have to spend much time on this. Most of you know about this. It's kind of what I call the legacy structure of healthcare in this country, and we haven't got them all listed because there's not room, but you'll see between hospitals and hospices and nursing facilities and other providers, CMS and Medicare in particular has 17 recognized provider types, and that's been the traditional link between the patient and their source of care. And of course, as we layer on more complexity here, you'll see how other things start to interact. But the patients and the providers, we still believe, form and will into the future form the core of this relationship. So if you can move to the 5th slide, Chuck, you'll see now a light blue circle layered on now to the patients and providers. And this is where the recent changes that have been announced are starting to enter into the picture. So this light blue circle that you're seeing, the ring around providers, we've labeled safe, seamless, and coordinated care, which of course is what we're aiming for, emerging out of the old legacy systems which promote fragmentation and disrupted care. Now, these are just in their infancy of development, so there's a lot of debate over what the best form is, and in fact, there probably is no one right form. But I hope that all of you on the call have heard about medical homes, which have been around now for a number of years and figure prominently in the Affordable Care Act. There's been a lot of press recently, including in the Washington Post yesterday, about accountable care organizations and pioneer ACOs, as they call them. Dennis and I have worked a lot on that one on the right side of this diagram, community-based care transitions programs, which comes out of ACA Section 3026. These are new ways of conceptualizing the work we do and making it possible to serve patients in seamless and coordinated ways. And we think this is kind of one of the first innovative ideas that's being layered on this system. If we can go to the 6th slide, Chuck, this one now has another dark blue ring around it, and now we're starting to plug into the energy of the American healthcare system as contained and expressed through its payment systems. So this dark blue ring around the safe, seamless, coordinated care brings in the various payers that play in this field. Now, the ones that we at CMS have the most influence over, of course, are the Medicare fee-for-service program on the right side, the Medicare Advantage plans on the left side, and of course the Medicaid and children's health insurance programs. But right at the bottom, at the 6 o'clock position of that dark blue ring, you'll see the new healthcare exchanges authorized by the Affordable Care Act, and those have just recently been brought under CMS orbit as well. And we also believe here that new and innovative partnerships with private insurers are going to make even more innovation and more help to the patients at the center of this diagram possible. We also believe that this is the ring in which the suppliers interface with the payers in new and innovative ways, and we're actively soliciting your ideas as the supplier community over what those new arrangements and new ideas can be. And as we move now to the next slide, the 7th slide, Chuck, this is the one that now adds the triangles of incentivization and penalties at the top of the diagram and adds a little rings of what look like moons orbiting around the planetary system here. And these are both incentives and penalties. We don't have time to go into them all, and now you should be starting to feel overwhelmed as we get to this slide, because this is where it gets really complicated as we implement. Each of these little circles you see has to be implemented separately in a traditional siloed way by CMS. We have quality reporting initiatives. We have various shared savings programs, which includes the ACOs, readmission penalties, both the EHR and e-prescribing meaningful use incentives. In the next few years, a physician value modifier, the hospital-acquired condition or HAC payment, value-based purchasing, and it goes on and on. All of these things that you're seeing on this diagram rightly do cause, when people first study them, confusion and a feeling of overwhelm. And what Dennis and I are trying to do in this presentation is start at this peak of overwhelm and now start to impose some order and organizing principles on it. And Dennis is going to guide you right to a feeling where we hope you've got total control over what this means in your life.
So thank you, Paul, and I'm going to pick it back up and continue to move very quickly. And on slide number 8, this will be the slide that if we had to kind of say this is what it's looking like, the whole picture all at once, this is the most complex slide. We've added one more thing at the bottom, and that is this foundation of tools that are available to help patients and providers and new organizational structures and others to navigate and work within this system. I won't mention all of the things, but a few prominent ones would be electronic health records. Another one would be demonstration programs to test new and innovative ways of payment that result in better care, better health, and lower costs. Consumer health plan labeling, which is part of the new Center for Consumer Information and Insurance Oversight, that's going to create a label for health plans, not unlike the label that you see on the side of a can of soup when you buy it, that kind of has the same facts on every food item, so you can compare things like trans fat and sodium content and so on. We're going to have that kind of labeling now in healthcare, which I think is very, very exciting. And then a lot of traditional tools like the quality improvement organizations, technical assistance, the transparency and public reporting systems like Hospital Compare and more. And I think the bottom line on this slide, I'll just call your attention to a quote from Don Berwick that was delivered at a recent American Hospital Association meeting in April. And Don said that at the core of this new system that we're building is this idea, and the quote is, instead of payment that asks how much did you do, the traditional fee-for-service and volume approach, the new system clearly moves us toward payment that asks how well did the patient do? And that's really at the core of it. If we could shift to the 9th slide. So back to the question we started with, new tools, new incentives, new disincentives, new organizations, what does all this mean? And I think it all adds up to something that I think is powerful and really quite simple for patients, for providers, for suppliers, for those of us who are working to create the new healthcare system together. And that last slide, slide number 10, we should be on now, is I think in a very simple and straightforward way, it means that doing the right things for patients will become easier, and it means that doing the wrong things will become more difficult. People in the current system don't want to do the wrong things. But the system incentives, the old system incentives, are for things like volume, not quality, not better care, and not better health. The new system, as you can see, is constructed in a way that puts those things at the center. And increasingly, they will matter more and more and more. And as they matter more and more and more, the focus will get more and more and more on health, on quality, on patient care, on integrated and seamless care. And the incentives are going to align with that in ways that they haven't in the past. And that's, I think, the very encouraging news that we have to deliver today. And with that, I'm going to turn it back to you, Dr. Denham. It's been a joy to join you. And we're going to hustle off now to our meeting with Dr. Berwick and in another part of the building, which we hope is not on fire. So talk to you soon.
Thank you very much, fellas. We really appreciate it. Joe Buckhannon, who is the senior advisor to Dr. Don Berwick, the administrator, who is our next speaker, was unable to be available at this time, and so we have a audio recording that I recorded yesterday because he really wanted to participate in this. He believes that the supplier companies are critical, and relationships between providers and suppliers are critical, so he wanted to be part of the webinar, but we recorded his voice, his message, and his answers. Kyle, would you please play Joe? It's really a great pleasure to introduce Joe Buckhannon. Joe is one of our leaders of the Centers for Medicare and Medicaid, working very closely with Dr. Don Berwick. And Joe is truly a role model of social entrepreneurship, having come from the Institute for Healthcare Improvement, and is really bringing dynamic innovation and bold and courageous support of innovation in the Centers for Medicare and Medicaid. We've worked with him for years, and he has really had a terrific trajectory and is meeting many of the challenges that we face today. And we've asked Joe to give us an update on CMS and where they're going and the partnership for patients, but also the emphasis on innovation and the opportunities that we need to explore with our great supplier companies in America. Joe?
Well, thanks very much, Chuck, and we really appreciate once again the platform that's being created for us here to have conversations about quality and safety and how we can all contribute to improving quality and safety. The news from CMS, I think, is exciting and dynamic. We continue at a very high level to pursue the goals of what we call the three-part aim, which is seeking to improve the quality of care itself, seeking to improve the health of the population, and seeking to reduce costs through improvement at the same time. The goal is to create a high-functioning, excellent healthcare system that's also sustainable for the long term. And I think that everything we do is aligned behind those particular targets. With a specific reference to the goal of improving quality within healthcare itself, within those facilities and settings where care is actually delivered, and reducing costs at the same time, we have launched, as most of you know, in the last month and a half, we've launched the Partnership for Patients. And the Partnership for Patients is a national partnership consisting of stakeholders from across the country who have said that they will join us in pursuing our two primary objectives. The first is to reduce preventable harm in hospitals around the country by 40%. Between now and 2013, and the second is to reduce readmissions by targeting avoidable readmissions by 20% between now and 2013 as well. We think that the reductions in harms and complications associated with this will be very, very significant, and we think there's a great potential for cost savings really on an order of magnitude of tens of billions. We estimate that if we can do this work in the next 3 years specifically, we could have the potential to avoid as much as $35 billion in cost to the system. So the opportunity to deliver better outcomes for patients and families by focusing on things like infection reduction and medication safety and surgical complication, and also care transitions, the opportunity, I think, is a great one. We know that there are pockets of success all around the country, and the question is, given the seriousness of the problem, can we take those pockets of success and make them ubiquitous? The early response has been terrific and exciting. We have over 3,000 organizations and individuals who have signed on with us, and over 1,600 hospitals around the country who have joined on. So we think that represents a great early signal, and now our focus will be shifting from raising awareness about the initiative to actually beginning to start to drive action and to help organizations around the country get started on either A, introducing the interventions that we know will reduce harm and improve care transitions, or expand the work that they've already done. A question gets asked often, which is how? How do we think we'll actually meet the goals of this initiative and meet the overall goals of the agency and the department right now? And I think the first answer that I like to give, and I think it's meaningful in the context of today's call, is that we'll do it together. There's no way that we make the change that we're seeking if we're not all pulling in the same direction. And so that means that providers of care, employers, purchasers, patient and family groups all have to add their weight to what we're trying to do and make very specific contributions. It also means, though, that there's a role to play for the supplier community, and I think we have walked on eggshells a bit historically around this and approached it with a bit of trepidation, but I think that the time has come to start thinking about this more seriously. When we talk about suppliers, when we talk about those who are making new products and introducing new ideas into the system. What we're talking about is innovation, and there's no way we can make the change that we're seeking without innovation. There's no way that we can address the challenges that we seek to address if we don't approach them very thoughtfully and apply all of our best knowledge and all of our best experience. A great deal of the work, of course, has to do with standardizing processes and introducing processes that are foolproof, that are safer, that protect providers and patients from harm. And I think that the supplier community can help us there as well. One thought or idea that I've heard bandied about at times is the idea that the supplier community itself can actually come together and talk about how it can make care safer, how it can create standards across products and across new innovations so that we can make certain that everything we're producing and introducing has as a sine qua non safety for patients and for their families. So I will welcome this call with interest and am curious to see what kind of conversation is generated in the course of the call, and I think we'll be curious to see if there's potential here for really pulling together and as we move in the direction of improving quality and safety and improving population health and taking cost out of the system through improvement. So, Chuck, thank you again for the platform, and we'll look forward to listening in on the balance of the conversation.
Well, Joe, we know that you have incredible demands of you there in Washington, and know that you'll jump off. So we'll ask you one quick question, and that is, as we proceed forward, is it fair to say that our suppliers of pharmaceuticals, devices, health IT, and services solutions must focus on value-based solutions, those that really deliver quality at a certain cost and really tie that to evidence? Is that a fair statement? That'll be our one question for you, Joe, before we let you go.
I don't know if I can say must, and you know, as I say, as a federal employee learning the ropes here, I have to be probably a little careful. But what I can certainly say is that the way the industry is moving, the direction we're taking is that, you know, we have to find a way to make the healthcare system sustainable, and the way that we believe we're going to do that is by improving quality and thereby introducing savings to the system. And so with that as a shared compass, I think we're all going to do well by patients and families.
Well, Joe, thank you very much. Godspeed in your journey there in Washington. Thank you for your tireless work. Joe is a guy that is putting in a huge number of hours per week, as so many federal employees are, and a great public servant. Thanks so much, Joe.
Thank you, Chuck.
So we've now heard from our CMS leadership. They're under tremendous pressure at this point in time to implement a number of the programs that have been outlined, and they can only say so much regarding companies, products, services, technologies. My job now is really to focus on some of the really practical issues that are at play. Again, our leadership and participation with the National Quality Forum is fundamentally grounded in the National Quality Forum Safe Practices. I'm on slide 26. These remain to be the most evidence-based and most recent reviews in the major areas where patient safety and performance improvement is focused. And as of yesterday or today, I believe, the notification will be on the NQF website to state that Safe Practice 22 has been updated. The Safe Practices may be downloaded from the NQF website and may be used by suppliers, providers, and purchasers. The article that we wrote a couple of years ago, the No Outcome, No Income Tsunami, that can be downloaded from the Safety Leaders website, really provides a guide to what was happening and what is happening with the move from procedural-based mini transactions to value-based reimbursement of care, and how we need to reconstitute our efforts and focus on point of care, episode of care, and contract horizon. However, as we deal with supplier companies, the next slide, slide number 28, really addresses the elephant in the room. And the elephant in the room is trust. In almost every industry sector, however, in our sector of healthcare, trust is at an all-time low. Suppliers don't trust providers, providers don't trust purchasers, purchasers don't trust providers, and providers don't trust suppliers. And there's incredible financial pressure. We've had our financial meltdown, which really threatened a lot of the premises that we had, that we function by as we function in a financial world. And trust is at an all-time low. So as I move to the next slide, 29, a book that we highly recommend, which is The Speed of Trust, really addresses what we found in 25 years of social entrepreneurship and 25 years of commercial entrepreneurship, that the best relationships are based on trust. And trust in our field is tied to data, evidence, measures of outcomes, process, structure, and person-centered measures of caregivers and patient-centered metrics. We find that the greatest and most important barrier that must be overcome in establishing partnerships is trust. And as you read deeply into the Covey book, you'll find that consistency and messaging and transparency is absolutely critical. So as I move to the next slide, slide number 30, and I'm going to set up my colleague Frank Giotto, I want to draw attention to the fact that we have put forward this framework of the performance model gap. Our is-state performance in U.S. healthcare, I'm circling with the highlighter pen, is really based on the fact that we've got 30 preventable deaths an hour. We have 15,000 seniors that are dying every month from the OIG report. We know that our typical quality improvement initiatives, as evidenced by Chris Landrigan's report in the New England Journal of Medicine, show that we're flat in our improvement, even in a progressive state and performance improvement. And this is really because care is increasingly fragmented. Seniors that have 5 chronic conditions will have, on average, 37 doctor visits. They'll be given 50 prescriptions by 14 doctors. So we're treating sicker and sicker patients faster and faster with more complex illnesses. We know that if we look at design as healthcare engineering would define, that idealized design that was undertaken by the Institute for Healthcare Improvement and other organizations to define many of the new innovations that we've seen in the bundles for a number of areas of adverse events, started with saying, in a perfect world, how good could it really be? And then we have described the term best achievable performance. Clearly, a 75-bed hospital with 9,000 admissions can't be the same as a 300-bed hospital with 15 to 18,000 admissions, which is the average in America of 14,800. We need to work with our supplier partners to come up with the right products, technologies, and services that would allow us to close those gaps. So typically, we'll come back to this performance gap concept as we look at new innovations. And then as we try to close the gaps, embedded in the safe practices and much of the work TMIT does is awareness of the performance gaps, then accountability of those who have to close the gaps, whose behaviors must change in leadership positions right down to servant leaders at the front line, and then investing in the ability, which are skills, knowledge, dark green dollars, light green dollars, to invest in technologies, products, services, and education to close the gaps. And then there are the line-of-sight actions that must be undertaken to close those gaps. We recommend that this be a model that be used by suppliers and providers as they move forward. In the article, may I have the envelope, please, where we use the Dennis Quaid story of the twins that his twins were almost killed with 2 overdoses of 1,000 times the heparin that was intended. That was purely a system failure. It wasn't bad people. It were the systems, that these administrative support systems that we all really need to have in place, and for which we need new products, new services, and technologies. We're left with, at the end of this article, that administrators that are looking at a new product or service should ask one question. May I add the envelope, please? What is the performance envelope of safety, quality improvement, and high performance that new product or service might deliver? And then as we look at the market penetration curve that our supplier companies look at, our market of 5,700 hospitals, 35,000 organizations, over 800,000 doctors, and 1.6 million nurses that represent the majority of our workforce, as we look at them adopting technologies, we're reminded of the market penetration curve that was pioneered by Edwards and later by Crossing the Chasm, the book by Wolf, that about 2 to 3% of the marketplace are innovators. About 12 to 15% are the early adopters that are in the early part of the market over to the left of this diagram. But it's really the middle of the market that represents 70% of the market, right in the middle part of the market, that everyone needs to be targeting, and that we really need to work at targeting mainstream market beachheads. I'm on slide 34, that represent the bulk of the market, and that we need to focus on best practices that are enabled by product, services, and technologies, and then adoption barrier weapons that can break down the adoption barriers, reimbursement strategy, care process design, guidelines, systems integration, patient education, and other things like training and support, that our supplier companies really need to start at their heart with the best or better practice that is enabled by the right combination of product, services, and technologies, and then that we use different techniques to defeat the adoption barriers that we have when we have an adoption barrier set that really causes, on average, the adoption of about a rate of about 17 years. It takes about 17 years for evidence-based new practices, and then at 17 years, we probably level off at about 55%, which is the famous McGlynn article from RAND. One of the final slides I'll show is the solution development process. So if our supplier companies and our providers look at the best practices first, not at the technology, which we're so in love with, and then look at the product, services, and technology set. Dr. McDowell will be talking about new innovations and having direct visualization of catheterization of the bladder, that we need to look at not only the product, but the service and technology set, and then we need to look at the value adds. What can we do to enhance the ability of folks to adopt them? And then the arrogance that we have as providers, we need to address our own arrogance and say, wait a minute, we really do need to look at the dollars. That's not all about the suits. We should look at total cost of ownership, because when we have a technology or product that we want the C-suite to adopt, we need to know that they need to be very careful about resources, and we need to calculate what is the total cost of ownership and really look at those issues. I'm going to turn the helm now over to Frank Guilletot, my colleague of almost 20 years. Frank is a product development leader. He has a background in mechanical engineering and then product development and engineering from the standpoint of services engineering, and that is combining product, services, and technologies. And we'd like to have Frank kind of address one of our recent development areas that we all are working on, and that is the modeling and developing impact calculators so that providers can use their data with evidence-based decision points and be able to apply their data and aggregated data to make good decisions. Frank, would you please take over?
Sure. Thank you, Chuck. And I'm going to kind of keep our pace going here so we have ample time for questions later. And what I'll be touching on is actually a topic that was addressed in our webinar earlier this year on February 17th, which we co-hosted with APIC regarding a focus on healthcare-acquired infections and development of a business case around this. So if you're interested in more details, we have a full set of transcripts available online on our Safety Leaders website. So what is Greenlight, and why do we have this initiative? Well, we've heard it. We have an increasing pressure with limited resources and competing priority, and it's become increasingly difficult to fund new initiatives, or in this case, as we're talking suppliers, acquire new technologies that will impact the quality and the safety. And this is particularly true in the space of quality and safety, where the outcome is a non-event. So you're not increasing your volume by having a new magnet or other. In many instances, what you're looking at is reducing what would be considered a quality, and therefore the less you have, the lower the event, and therefore you'll have a direct impact. So we've arrived to a conclusion. In order for us to open up, if you would, the awareness, we need to be able to formulate and format our language to the leadership so they understand how this can impact the bottom line. And specifically, in this case, since this is Greenlight, our focus is the CFO. with the intent of having the CFO greenlight the projects and make, in some instances, out-of-budget decisions to allocate funds towards a project that's going to have a quality and safety impact. Next slide. So what we're looking at is developing, as I was mentioning, a series of CFO-validated impact models that will quantify the magnitude of the harm and allow us to position and evaluate quality initiatives, and in this case technologies, based on a financial, operational, and clinical. And we want to do this in a kind of a transparent manner so that we're making these models available to all the stakeholders within the organizations, but also with the outside stakeholders, such as suppliers, so that we have a common framework that allows us to have an opportunity to evaluate new technologies or new processes. What we've encountered, though, is a significant challenge in terms of the data. As we all know, data is not readily available. When it's available, it's usually not useful, and many of the quality departments are struggling with that because they rarely have access to their own cost data. And when it is available, there's significant variation in terms of how the costs are allocated, and it's an incomplete set that is hard to build on for a business case. There are point estimates available in the literature, but many a times these numbers are not very representative of an organization. And as Chuck was mentioning, much of this information is built off research that's been done in areas where an organization has a different cost structure, so it may not be reflective of what more of a mainstream organization incurs. So in order to address that challenge, we've been working with a broad range of data sources, started with national databases that are readily available through administrative cost data. But as we drill down into specific areas, we are actually working with a number of these collaborators that are listed there. This is a partial list, who are working with Greenlight to provide their cost data so as for us to be able to ascertain the cost of harm in specific areas. And as we collect and analyze this data, we segment it by the type of organization, by the geographic location, whether it's a teaching and non-teaching, so that this information can then be tailored to an organizational profile. So as an organization goes in and uses the tool, they can really map it to what is most representative in their size. And next slide, please. So we're focusing on, our first focus is on HAIs for Greenlight, and we're tackling these 6 healthcare-acquired infections, SSI, CLABSI, VAP, CAUTI, MRSA, and C. diff. And we've started with at this point, a high-level population-based model, which uses both a meta-analysis of the literature and uses point estimates, and then national data sets that are administrative data sets that are then subsequently validated by our Greenlight collaborators. And our next phase of the project is to start drilling down to specific patient segments where we evaluate the high volume, high impact areas, so that we can truly start identifying where we can have the most impact in terms of the intervention. So our patient segments in this case are going to be focusing as it relates to SSI around colorectal, cardiac, and orthopedic, which are tied back to some of the hacks as well as from what we've seen in the literature and from what has been provided by our Greenlight partners. There is a significant opportunity. So once we're able to ascertain that cost, then we can then work within the framework of these models to understand where we can have the greatest impact based on the technologies or the processes that are currently available. So this information, as we progress and as we release it, will be available through a series of venues. One of them is publications, and we can go through the following slides pretty quickly, but also through the website that some of our partners have made available. So if we go to the next slide, you'll see that we have APIC as a a joint collaborator. And next slide, you'll be able to see, if you go on their website, these models are now available online for you to use. Next slide, same with TMIT's. Actually, this is a snapshot of the model, which is an Excel-based model that we've developed for APIC. Next slide. This is where you'll be able to go on Safety Leaders and access the very same models. But this is for both the meta-analysis data as well as the administrative data from the HCUP database. So next slide. And this provides kind of a brief snapshot. So it's segmentation of hospitals available. Next slide, as well as the region, the teaching status, and therefore you can affect those variables and give you a specific profile that is most representative when you start looking at the cost. So with that, Chuck, I'll turn it back over to you.
Carl, if you want to hand me the ball, please. We will now move to our next section of Carlos Nunes, who is the Chief Medical Officer for Carefusion. We want to congratulate him regarding this recent post. He is responsible for establishing clinical protocols across Carefusion businesses. And in full disclosure, we've had a relationship for some time with Carefusion, who actually funded the movie Chasing Zero, Winning the War on Healthcare Harm, and other initiatives that we participated in. And so for conflicts of interest purposes and disclosure, we want to make that clear, as we will with each one of the other following speakers. And we'd like to have Carlos give us a quick briefing on a partnership that occurred with one of our states and did produce lives saved, dollars saved, and value to the community. Carlos, please take it away.
Thank you, Dr. Denham, and thank you all for joining. I just wanted to take the first couple of seconds to lay the groundwork for the slides I'm about to show, really based on some of the things that the folks from CMS said at the beginning of this webinar. We have a tremendous opportunity as we look forward over the next 10 years or so in American healthcare. And when you look at between the Affordable Care Act and the talk on Capitol Hill inside the Beltway about deficit and debt reduction, we are being asked as an industry to reduce the expenditures for healthcare by hundreds of billions of dollars over the next decade. I mean, just government expenditure needs to be reduced, if you want to believe what they're saying, by close to $1 trillion over the next 10 to 12 years. That's somewhere between $80 and $100 billion a year. We've got to find ways to wring out of the system. And focusing on things like preventable events, including healthcare-associated infections, is a great way for us to start this conversation and to get the ball rolling. Because if you want to believe the figures that are out there, just healthcare-associated infections costs tens of thousands of lives every year and tens of billions of dollars every year, and it's a great place to focus. And I'd like to talk a little bit about, if you go to the next slide, please, something called the Alabama Hospital Quality Initiative, and you can actually forward to the very next slide. Back in 2002, this Alabama Hospital Quality Initiative was looking for a way to provide hospitals in Alabama with technology that could help them not just detect but manage infections, try and understand which patients were at risk for developing infections during the course of their hospital stay, and identifying them early enough so that appropriate interventions could be taken before the infections happened or after the infections happened, so that they could lessen their impact on things like morbidity, mortality, length of stay, et cetera. The initial pilot program back in 2002 included 6 hospitals, and they found that there was a reduction in hospital-associated infections of about 13%. Now, currently, in 2011, we've got all 71 hospitals in Alabama enrolled in this quality initiative. The partnership was extended to include the Alabama Hospital Association, and the state and other entities are now using benchmarking data to provide incentives as pay-for-performance indicators. So if you look at the slide that's up there now, the aggregate analysis, in Alabama, 51 hospitals who have participated in this program using this technology that is provided by a vendor. Obviously, the vendor is Carefusion, but it could be any sort of technology. The fact is that you can partner with a vendor to look for solutions that make sense. And in this case, the partnership with this vendor, with the hospital association, and even with the payers, looking at the aggregate analysis, 51 hospitals saved 6,000 patients from hospital-acquired infections. If you look at just the Blue Cross Blue Shield of Alabama members, they protected over 1,000 patients from these HAIs, looking at a bottom line savings for hospitals of about $34 million. Just Blue Cross Blue Shield realized a benefit of $15.2 million. And over the entire state of Alabama, it's $49.2 million saved. If you go to the next slide, please. You'll see that looking at benchmarking Alabama versus the rest of the country, 56% of the Alabama hospitals are rated as excellent in their benchmarking for nosocomial infection marker performance. 94% of hospitals are performing better than expected, and 53% of the hospitals in Alabama are improving in their nosocomial infection marker performance. So looking at the chart compared to the national view, the Alabama hospitals, in the way they are dealing with hospital-acquired infections, is quite inspiring. And if you go to my last slide, Alabama served as a model where this could be very successful and is starting to be rolled out across multiple states, Texas, New Jersey, New York, California, and Illinois. You see that at a variety of levels of participation and funding, you're seeing this model roll out where other states and other organizations recognize that all parties involved, the providers, the payers, the providers of services, and the providers of products to hospitals all need to get together and get behind these initiatives. As I said at the very beginning, we stand at the beginning of a tremendous and transformative period in American healthcare where we are going to be asked to continue to improve the care that we deliver while decreasing the cost and making our healthcare system more sustainable. Hospitals and providers are being squeezed by higher levels of utilization and potentially lower levels of reimbursement, and everybody needs to partner together so that with the patient at the center of the equation, the hospitals, the providers, the payers, and the vendors who provide the goods and services to make healthcare work on a day-to-day basis need to partner so that we can find ways to deliver the best, highest quality care at the most reasonable cost in the most efficient manner. Hopefully that was within my 7-minute time period.
It was, and you did a terrific job. And I want to remind our audience that this webinar is a sampler, and we will take a deeper dive in 2 deep dive webinars if our audience wants us to. There's a poll in the lower right-hand corner of your website page. Our Net Promoter Scores of the first of the 3-part series were so high that we are planning to do a deep dive in this partnership area. We'd like to have all of the attendees respond to the poll in the lower right-hand corner. However, we've already made the decision that we're going to do a deeper dive. So this is really an appetizer or a teaser or a preview of a much deeper dive that we're going to do over a 2-webinar series on how to put together provider-supplier partnerships, deal with conflicts of interest, deal with best practices, and we have Dow Biggs, who is the Chief Medical Officer for Blue Cross in Alabama, who's going to be a reactor to following the next 2 speakers, and that's why we're doing a rapid-fire set of presentations in this particular webinar with a deeper dive, but we look forward to Dow to respond. And Dr. Gladstone McDowell will give us about a 5-minute overview of a technology, and also we'll be addressing the barriers that we face as we look at new technologies that open new vistas of opportunity to reduce harmful events such as urinary tract infections with new technologies, but they pose new challenges because they cost money and they require new skills and knowledge and breaking down the adoption barriers. Dr. McDowell is one of the directors of TMIT. He's one of our nation and actually probably one of our world's leaders in pain management. He is board certified in multiple specialties. He is a urologist, a urologic oncologist, practiced anesthesia, and then became a pain management expert. So he really sees the full continuum of care. He's also become a patient safety officer, taking the comprehensive training through the Institute for Healthcare Improvement, and one of our leading experts that is advising us at TMIT. Dr. McDowell?
Thank you, Dr. Denham. I'd like to compliment Dr. Nunez. I loved his introductory statement about what we need to do with HAIs. What I'm going to do is talk about the urinary tract infections and the fact that we have a significant problem with catheter-acquired urinary tract infections. Just briefly, we know that blind catheterization can be problematic, and usually it is a difficult procedure with somebody with normal urethral anatomy. There is a bulbous urethra, there is a sphincter, and then there is a prostatic urethra. It's further complicated in older patients or patients who have urethral strictures or false passages. And then the healthcare provider, may not be the most extensively trained person. What we found is that looking at a number of studies, we looked at a study from the Scott and White Hospital where they looked at over 2,200 Foley catheter placements over a 9-year period. This was a retrospective analysis, but they found that 1.4% of patients had some type of catheter-related trauma identified. And then if you looked at these patients, 33% of them required some type of corrective surgery that ranged between $8,000 to $17,000. We know that the care for urinary tract infections may cost upwards of $11,000, with 12% of people acquiring a UTI within 2 weeks of a Foley catheter placement. We know that cystitis may cost up to $500, and septicemia may cost $48,000 to $50,000. And 1.9% of people in this study acquired septicemia from this. If you look at the causes if you look at the problems with difficult catheterization, you will see that a significant percentage of them are bladder neck contractures, but also just simple things like BPH that we see in routine patients. Navigating this can be problematic, and oftentimes our nurses are not adequately trained for this. So what we have done is we've identified a technology, and you can see from this slide it just talks about the difficult anatomic areas that need to be passed by. But, we talked about physicians redesigning care processes and now becoming invested in care management. What we've identified is a potentially important tool that we think will help to solve some of these problems. This is from an Ohio company that came called Carefusion that came up with a real-time visualization to enable first-line responders to see and navigate the urethra. And then if they run into problems, they can stop, redirect, or contact the urologist for further instruction or assistance. You can see here that it shows the difference of just a tight urethra or sphincter, or somebody with a urethral stricture, a false passage. So this reduces the potential for escalation procedures and improves the quality of care for patients. The slide here demonstrates the actual system. A specially designed Foley catheter has a visual fiber within it that can be guided by the care provider who is looking at a monitor. This increases the frequency of first-pass catheter placements, reducing the need to get an expensive consultant in there for an injury, and then reducing the potential movement to an operating room scenario here. This can be very important in the...
Gladstone, just to keep us on time and have adequate time for Q&A, we believe in discussion with the Gladstone and the technology provider, and again, with the declaration of conflicts of interest, presuming with every product that we talk about in this webinar, but this system poses the classic dilemma in that we have to re-engineer care, clinical, operational, and financial care, and providers who believe that this could be a technology, one of many, that could be undertaken to reduce adverse events, have to really weigh into the cost at point of care, episode of care, and purchaser contract horizon, and actually have to get into the business of building business cases so that we can take a look at some of these new technologies that were never envisioned when our purchasing systems and our purchasers had codes for payment, and we've got fully loaded cost of treating urinary tract infections. So is that a fair statement, Gladstone, that this is a good example of something that could be revolutionary, but that we have to get into the case of developing business cases and really understand the financial downstream costs of a urinary tract infection that might be more than just antibiotics?
Yeah, I would absolutely agree with you. And in fact, this actually factors into the pending Medicare Shared Savings Program in the Affordable Care Act, because, you know, they talk about encouraging investment in infrastructure and redesign care processes, focusing on efficient service and high quality. And I think that this particular system enables us to train nurses to be able to catheterize patients under vision and avoid false passages, urethral trauma, you know, even simple things like inflating the balloon in the urethra and avoiding the future escalations for procedures and subsequent urinary tract infections that may result in sepsis and, you know, prolonged stays within the hospital or even ICU stays. So I think that you're absolutely right. This innovation fits into the whole value-based solutions that we're all looking for.
The whole dilemma that we're faced in, that we're really now going to have to be responsible for a continuum of patients and the fully loaded cost, as we do when we look at infections that were covered earlier. So I'd like to shift gears, and thanks, Gladstone, for keeping us on time. We're only about 3 or 4 minutes behind on our flight plan. Reggie Holliday is an absolutely terrific patient advocate and has been a terrific voice of the patient. And Reggie, we'd like you to keep this again to 6 to 7 minutes so that we can turn then to Dow Briggs to kind of respond to what he's heard representing the purchasers. And then we'll have ample time for Q&A and come back to each of our speakers. Reggie, take it away.
Thank you so much, Chuck. I'm so glad to have this chance to talk, especially after hearing such wonderful other speakers earlier within this presentation. The thing that I wanted to add, and I don't know if my slide set was available. Yes, thank you. How important the patient advocate is, and that oftentimes that person is a mother, a wife, a family member, a parent, and how much that adds to the dialogue. The painting you see before you is one or two people within a painting that's really large. It's a 3-panel piece. And you might recognize that woman. That's Sorrel King. And she's got a shield in front of her, and that's the book Josie's story. And she wrote a really powerful book about what happens if you don't listen to what the family member has to say about the care situation. When her 18-month-old was hospitalized, and she tried to stop narcotics from being given to her child, and that unfortunately led to the child's death. A very similar experience Dennis Quaid had, except for he had the beautiful experience of his children getting to live. And she decided to work with the hospital to try to change this for other people so they wouldn't have to suffer. And one way to do this would be to involve patients, family members, mothers, into the dialogue, because we are very, very interested. There is nothing more important to us than our family members, and we'll do everything we can to try to support them in their care. If you could put up the next slide, please.
And Reggie, you know, in our effort to keep on time, I don't think we've emphasized that you are the artist and that you use art to help communicate this, and that you have been very actively involved with CMS in the initiative that we've partnered with them on to bring patients and families into the infrastructure of the quality movement. And we want to make sure that people know that as they look at these paintings. So keep going.
Thank you so much, Chuck. The second painting we have here is about teaching people how to cope with pain. Now, one of the parts of the care paradigm, and though I have heard throughout this call a lot of emphasis on that patient is center, the patient is more than center. The patient is part of the whole. You know, I want you to think of more like a Ring Around the Rosie, or we're all together holding hands in this scenario, right? So we are trying to participate in our own care, and as caregivers, of course, participate in the patient care. So you have here an individual holding like a garland of faces that are the symbol for the pain chart. And as you can see on her face is the pain of dealing with the patient, dealing with the patient experience, and how those cartoon little faces just don't hold up to the reality of true pain, and how we want to bring in the real experience of patients, the real dialogue within mothers and families, and how if that's accepted within the conversations like the one we're having today, that can change the entire paradigm of care. In the next slide, you'll see a mother actually flying because we're running out of time. The time is now, the time for data access, the time for listening to what patients have to say, the time for increasing awareness of what's going on within these initiatives and hospital-acquired infections within our general population is now, and we are going to save future generations by doing that. Next slide, please. And don't forget the dads. We have a tendency within society to put a lot of caregiving within the world of the mother, and 70% of caregivers are mothers, and hence the mom concept, but at the same time there are fathers that are doing this incredibly wonderful, diligent work, and those need to be remembered as well, and oftentimes they're doing this while they're ill. Finally, we have individuals within our society and government that what they do is they take the different suppliers, like you'll see there's hieroglyphics in the background of this image, that are the different logos from businesses, and they'll explain what those mean. There are wonderful women working in government right now with children at home, and each day they explain to us how what CMS is doing, what the ONC is doing, what's going on within supplier and business affects your care. And finally, in closing, I wanted to say how incredibly glad I was here, Dr. Gladstone McDowell speak about urinary tract infections, because that was one of the problems we had with my husband when he was hospitalized, and how little people were willing to listen to the fact that he had a urinary tract stricture, and how little as a parent and patient and caregiver I had access to correct protocol and care for urinary tract infections. And really, truly, one of the major points I would have to make would be involve us in all elements of the conversation. If you involve the patient and caregiver, we're going to get better care outcomes. Thank you.
And you've kept us on time, and thank you so very much, Reggie. One thing that we are finding is that our high performers are incorporating messages like what Reggie just shared and have patients and families on the teams along with working with the board of directors. And so frequently we as physicians get so technical and think that this is a bunch of soft stuff and a bunch of fluff. However, if you look at our high performers who have incorporated patients and families and patient stories involved in the board, that releases endowment funds of those organizations that can buy the technologies, to buy what we saw with the Carefusion solution, which is called AIMS, the Automated Infection and Mitigation Systems, the technologies that Dr. McDowell had shared, and the other technologies that for which we may not have a reimbursement code or something that a financial officer of a hospital will say, well, we don't have that in the budget, so we can't buy it. It is absolutely amazing how these patient stories can get the boards of directors with one 20-minute discussion and a show of hands can fund multi-million-dollar technologies that can be life-saving. And so the power of stories is absolutely magnificent. I'd like to turn to Dr. Dow Briggs now and want to thank him for being a participant on this webinar. Their state is suffering tremendous hardships with the recent flooding, and it's very, very nice of him to participate with us as a reactor. Too hard for him to be a presenter this time, but in the future we'll ask him to. Dr. Briggs, we'd like to have you first because we have enough time, give us the snapshot of how the partnership had been pulled together in Alabama with the solution with infections, and because so many folks believe that we can't get hospitals to work with technology suppliers to work with hospital associations and work with purchasers. And I think this is a shining example of leadership from your side, from the purchaser side, to be right there and to step up. I think too frequently we believe that no one will step up, and I think this is a great example where people from the purchasing side, that there are physicians that are in leadership positions that can articulate this. Could you give us a quick 30-second or 1-minute kind of capsule of how that evolved, and then maybe react to our speakers before we turn to Q&A?
Sure, that'd be great, Dr. Denham, and I do, on behalf of Blue Cross Alabama, appreciate the chance to join the group. The speakers before have done a really wonderful job at talking about some of the issues. Blue Cross of Alabama joined in an early partnership with the Alabama Hospital Association to look at hospital-acquired infections. We did a data look at our state. We saw that there was a significant problem with hospital-acquired infections, and so we, along with Carefusion, and thanks to Dr. Nunez, we've been a good partner of theirs for several years. They brought a new technology to the forefront, and their technology was a novel, innovative data modeling program that took data from hospitals and mined it for information on infection rates. The hospitals became interested in it. We started with 6 hospitals. Blue Cross of Alabama funded most all of that initially. By the end, as he told you, we have all the major hospitals in Alabama that have joined together. We also partnered with the Alabama Department of Public Health, the Alabama Infection Control folks as well as the providers at the hospital. So that's sort of how we put that whole program together. It required effort on all parts, but it was really a win for everybody. It was a win for the patients because we were able to impact infection rates in our state. It was a win for the hospitals because they saw improved processes. They had a new technology. They were able to decrease their infection rates. Clearly a win for the payers as well from a quality and cost perspective moving forward.
Dal, I'm going to come back to you as with the question is, the elephant in the room is trust. And there, at a time when distrust is at an all-time high, how did you all build the trust across the hospitals, you as the purchaser, Blue Cross, the supplier company, and build the trust for a very, very effective, what we would call a social entrepreneurship enterprise that actually worked? I mean, trust is one of the biggest barriers. How did you build trust across these multiple stakeholders?
Probably a couple reasons, Chuck. The first one was we brought a group together, all the group together to look at what the issue was. So we sort of created a very early stakeholder meeting. We did it with some of the key hospital folks in the state. We also brought some of the significant other players in the state to the table to discuss what the issue was. We put it on the table. We kind of exposed what the issue was. And once we all realized that there was an issue, then we began to join together to come up with a solution. We built trust by making sure that all players were a part of the solution. What doesn't do well is when an insurance company provides a solution and expects everybody to follow it. We wanted the hospitals, the providers, the infection control folks, the patients to really all be at the table as we came up with a solution. The second thing was we used the data to drive the program. It's important that we make our decisions based on sound information. We had a good data source. It was very robust, and it was very revealing, particularly when you use some of the innovative things that Carefusion brought to the table. And then the final thing was we agreed to help fund some of it. And initially there was no part of Blue Cross really tied to the program other than providing the funding and the support for the program. We ran a trial period. We did a pilot, so we basically did a research experiment, and the outcomes were very good. And these were outcomes that were delivered at the hospital base and not something that was delivered through Blue Cross.
Thanks, Dal. I'd like to go back to Dr. McDowell now, and I put up the slide of pain that Reggie brought up, and Dr. McDowell will come back to you on the urologic solution and partnering in that space, because I think these technologies pose a huge challenge. But as one of the leading pain management innovators in the country, can you address for us some of the challenges that we face partnering with suppliers in the area of pain? It's we know that it's the #2 reason to see a primary care practitioner. 40% of cancer patients die with pain. That happened to Reggie's husband. We'll give her a chance at a later date to tell more of the story about her husband. She'll be in our next Discovery movie. But Gladstone, can you address partnering between suppliers and providers and where the big opportunities might exist today as a pain specialist?
Thank you, Chuck. Yes, I think one of the things that we find frustrating is that sometimes innovative technologies are identified, but they happen to be expensive, and they don't have enough data. They don't have the double-blind, randomized prospective trials on large groups of patients that insurance companies and workers' compensation likes to see, but there is no way to get data on them unless people fund these studies or we gather some community data. But we know that we need evidence. So sometimes there's a frustration in applying some of these things, but we can give people cheap, addictive opioids, and then what we're doing is we're just sort of increasing the aberrant behavior and the addictive potential for patients through an iatrogenic means while not really solving the problem. And I've sort of gotten away from that. I go and I try to find a solution for the problem now rather than trying to cover it up with medication. So I would say that we just need to find some way to bridge the gap between more effective, less dangerous, safer solutions that may cost more, but we need to partner together to gather data to prove that there are quality and safety benefits for these currently, because the old system of just writing a prescription for it just isn't working.
I'd like to have Reggie. Reggie is one of the best network patient advocates and will be a very active co-leader of our Care Moms program, which we will be launching as a grassroots effort to help put positive influence and reward positive deviance by healthcare systems in multiple areas. But Reggie, don't you believe that there are a lot of consumers out there that would be willing to step up and be more responsible in the pain management area rather than just be passive passengers on the pain train?
Oh yes, I mean desperately. There's such demand for being able to be actually listened to within the care paradigm. So many times the questions themselves, if nurses and doctors ask you questions like, "Are you all right?" Our societal condition of response is to respond, "I'm fine," the way that's phrased. So a lot of it is just rephrasing the question, figuring out ways to get people really part of the dialogue, utilizing things like Facebook and Twitter and social media, and actually communicating with people. Find out where they're really coming from, because people want to join in and they want to help.
Great. And Frank cut his presentation a little shorter just to keep us on time. And I want to come back to Frank. And I think that we're very excited about the wonderful participation that we've had, both from our better-known big brands in healthcare like the Mayo Clinic and Cleveland Clinic, but also some terrific frontline work by Catholic Healthcare Partners, Ascension, and other organizations. Frank, do you want to give a quick capsule of some of the trajectory work that we're doing that will be available and becoming online and in upcoming articles?
Certainly, Chuck. As I was saying, we're kind of taking a multi-stage approach, and our current focus is really on identifying the high impact and high volume incidences, at least as it relates to infections. So we've been partnering with these organizations. And again, our approach is to reach out to the frontline organizations. It's these folks are sometimes dealing with different challenges than an academic institution may have, and what we want to do is provide it in these trajectories in a kind of a high-level enough way where organizations anywhere in the U.S. could pick them up, look at how patients are worked up, and be able to derive from there what would be an acceptable idea of the harm and the cost associated with treating a complication, something that will give them a threshold of cost. We're not trying to account for every complication. We're really just building a ground-up threshold cost so that they can in turn take those numbers and to their leadership and look at where potential interventions, be it through a technology from a supplier and working with a supplier to build a case, or in some instances maybe processes, process redesign, training, education, that's readily available, but that sometimes isn't allocated because A, we can't build a robust enough case, or B, because the organization is just not focused in that space, or they don't understand how big of a problem it is. So it's been very rewarding. These organizations include Florida hospitals, just as we also work in Florida University, a broad range, and we're missing some on this slide, but they've all been contributing, and as Chuck said, we'll be publishing that information, the methodology, and the results so that everybody can use it.
Frank, further, and again, thank you for we cut your slides a little bit short. The next two slides that I'm going to show are what Frank and I would teach at the University of Texas as we would get engineers that wanted to measure everything with a micrometer. And it's important, I think, for people to have just the common sense. And I come back to our supplier companies that are on this webinar and really give them a little bit of a practical sense of what's important about data. Frank, do you want to go through this slide and the next slide, just quick 30 seconds on this kind of funny concept that we use when we teach engineers and product developers?
Right. I guess it's the comedy segment here of the webinar, but really, all kidding aside, much of the engineering design and traditionally has been done with an engineer-centric view of the world. Much of the design is taken in the laboratory, and rarely do we engage the end user early on in the design. So Chuck and I kind of coined this notion that in order to sell it, most of the time we spend a lot of time analyzing, doing all the in-depth analytics. So we measure it with a micrometer, and then when we start rolling it out to the market, and we're a little less precise, so we mark it with a chalk, and then ultimately when it gets released, we cut it with an axe. And then kind of the punchline is when we actually take it to the customer, we beat it to fit and we paint it to match. Now, all kidding aside, I mean, we see that regularly when we're looking at the deployment of certain technologies where we really do not understand the socio-technical aspect of rolling out something that is complex in a system that's going to have multi-layers of implementation, but also of implication. And many instances, this goes back to why it's critical that the suppliers and the provider companies work together, not only to build the business cases, but to make sure that when the technology is rolled out, we have all the elements in place and staged appropriately to accomplish the success, as well as an alignment of incentives so that both parties are in a win-win situation.
And really our message is to the healthcare services researchers who are becoming this new cadre of people in healthcare services engineering, and our message is to the supplier companies is you don't have to have perfect data. In fact, there is no such thing as perfect data. What's really critical is the hospital or the customer's data, and if you look at it from the provider side, the hospital or clinic, your data is the most important data. It should be complemented by a practical analysis, not with a micrometer, but since the fidelity of what you're going to do with, let's say, the new innovation, I'm going to come back to Dr. McDowell and then back to Dr. Nunez. But the issue is perfect data is not necessary, yet our health services and our public health folks want to analyze it forever. Then they'll say, well, it's not perfect, so you throw out the baby with the bathwater. At the level of granularity and fidelity of a CFO or a chief operating officer, you don't need perfect data. What you need is the floor of savings. And so what we do is we pull out comorbidities and say, well, what would be the very basic savings if somebody had no comorbidities for this solution? And if it will pay for itself without adding in all of these other complexities, you don't need to have journal club with a bunch of doctors that are going to debate the nuances of the DNA of a gnat's whisker. It just doesn't matter. But it's so frequent that we get so obsessed with the data, and if it's not perfect data, then we throw it out. And our supplier companies don't need perfect data, and nor do our providers, in order to make a good decision, an economic decision to do the right thing for patients. Gladstone, I'm going to come back. I'm coming back to the problem of catheterization. And I think too frequently our finance folks and our chief operating officers and what perhaps some of our clinical folks would call the suits don't look at the fully loaded cost of a urinary tract infection and the fact that when we traumatize the urethra and somebody gets a urinary tract infection in an older patient, they can fall, and there are many downstream things that don't come up on the grid when a CFO might look at the expense of a urinary tract infection. Can you just give us the picture of what the downstream costs that Dow might be paying for after somebody is discharged and after they have a fall, break a hip, etc.? The cascade of events that can occur are terrible. Can you just give us a good feel for that as a urologist?
Well, besides the obvious discomfort from a urinary tract infection and the need to potentially take antibiotics, I mean, the hope is that you would respond to that. But if you have an occult urethral injury that really goes unrecognized and may be discounted as just simply urinary tract symptoms, this can progress to further sepsis and the need for rehospitalization. Patients getting up to go to the bathroom at night because of urinary frequency or increased nocturia from some irritative focus would increase the risk for falls. Certainly, you know, we never want to have patients taking more medicine than they need to. There are unrecognized sulfur allergies that people may have, or even penicillin allergies. So from a medication management and medication error perspective, we always want to minimize what they're introduced to. Elderly people who have injuries like this end up being hospitalized a lot more. They have increased pain. They have myofascial pain that is often treated with opioids, which is unnecessary, but it's the easiest way to go. So there's a whole cascade from this. If you have a significant or a complicated urinary tract infection that requires increased instrumentation by the urologist or the surgeon, the cost for that escalates, the injury potential escalates, and again, occult infections may progress and require prolonged hospitalization. We've seen lots of people end up in the ICU with urinary sepsis, which can really be life-threatening, particularly in diabetic or immunocompromised patients, which can be cancer patients or anybody who is even older.
Gladstone, Deborah Scott, and I want to remind our viewers that you can submit a question in the Q&A window at the lower right-hand side of the webinar screen. Deborah Scott asks, are you aware of any technology that can assist with the identification of a UTI close to real time instead of retrospective? This technology you shared is preventative, but this is identification of a UTI close to real time instead of retrospective.
Well, I mean, just a simple urinalysis or even some urinary dipsticks can give you an indication of whether you may be dealing with something that may have an infection focus. I mean, that's perhaps the simplest, cheapest solution for that, but somebody needs to, number one, listen to the patient and then act on it. And, you know, as our consumer participant pointed out, we need patients to, you know, we need healthcare providers to pay more attention to patients and caregivers. Caregivers are very, very important. They oftentimes will give you a lot of information that the patient may be unwilling to or unable to share. So just a simple urinary screen, a UA, and then maybe a culture after that would be the first way to go. No need to spend any more money on more expensive technologies until you've answered that question.
So, Dr. Nunez, we have a question from Neeraj Chopra. What is the gospel of single source, or is there a best single source of content and clinical guidelines that you used for your Alabama HAI project? And number two, what is the top public source that you utilize to stay on top of the ever-changing content regarding clinical guidelines? Two good questions.
Those are excellent questions. As far as the Alabama Hospital Quality Initiative is concerned, really the guidelines used in the tool, and I don't want to focus too much on a tool or a product, I really want to focus more on the concept, is that it's the evidence that's based on the medical literature, which is constantly changing, meaning it is constantly being refined. So for example, when AHRQ or NQF or the CDC comes out with new guidelines for infection prevention. Those are incorporated into the tool, and as a healthcare professional who now works in industry, but first and foremost as a physician, I too rely on the medical literature and the way that the evidence in the medical literature reflects, really most recently in public policy through agencies like NQF and the CDC, to form my own opinion. So when we look at the development of new tools or the adoption of new processes, it has to be based on the medical literature, comparative effectiveness research, and that often overused term best practices. I think you also find that there are regional differences. There are also hospital and even intra-hospital specific differences. But for me to nail one source down, I think is probably not appropriate. The best take-home message from this is to use the medical literature as a guide to point you in the direction of what best practices are for your patient population, for your intended use, and for the regional and the individual patient populations that you deal with in your healthcare facility. And then the guidance of bodies like the CDC, CMS, et cetera. When you look at what's going on in the federal government, as most of you are probably aware, in 2011, fiscal year 2011 was the first time that public funding of healthcare in the United States outpaced or grew to be bigger than private funding. So now things like Medicare and Medicaid are responsible for more than 50% of healthcare spending in this country. And as goes CMS, so tend to go the third-party payers. I don't want to put words in the mouth of our colleague from Blue Cross Blue Shield, but for good reasons, because as the government realizes we are responsible for this huge bucket of money, which makes up an overwhelmingly disproportionate part of the federal budget and our GDP, we've got to come to terms with how best to fund healthcare. And when you look at infection prevention, it is the work being done by HHS, by CMS, within the Office of the National Coordinator for Healthcare IT, reflected in the work done by AHRQ and the CDC, trying to align everybody to accepted best practices based on the medical literature and the nursing literature so that we can deal with these problems in ways that make sense, again, based on evidence.
Great. Thank you so much. I'd like to come back to Dow if he's still on the line. And two questions. One is, how receptive have the other Blue Cross organizations been across the country? We know they're really wonderful people in the national organization in Chicago, Chris Suzui and her colleagues, Alan Korn and others nationally to help pull together all of the Blues. But when you've talked to the other chief medical officers of Blue Cross Blue Shield, how receptive have they been to the concept that maybe there are other states where other technologies might be partnered in the way that you all did it? Did they like what you did, and what was their reaction?
In general, the reaction has been very positive, Chuck. I think all third-party payers, and I can't speak for them all, but I can tell you all the Blues are looking to learn from each other. Collaboration and sharing of best practices is a very quick way to get to a solution. Instead of going back to the drawing board and trying to come up with something, some of the innovative ideas that we share amongst each other are not necessarily new innovations, unlike the technology that Dr. Gigato discussed, or Dr. McDowell. And so what we've done from the Blue standpoint is we've set up something that's called a database called Lasting Operational Solutions. And what this is a national database that has a variety of categories in it, including patient safety, hospital-acquired infections, et cetera, where the Blues put all the information on how they develop their programs into this database, and then it's shared amongst all the separate 39 Blues with contact information, vendor information, so that it's very easy to adapt it into their area. And I really think that's going to be the solution down the road. We can't all come up with our own siloed approach, and from the Blues, at least, standpoint, I think they've all come together significantly significantly over the last couple of years to make sure that is an area of focus.
So second question, if one had a technology like what had happened in Alabama with Carefusion, but a different technology, and they were in their state and they had good penetrance of the Blues, who's the key person to kind of contact and say, listen, we've got a pretty cool technology, we'd like to partner with our Blues, we'd like to see if we might undertake a demonstration project? Who's the best person, or is it different in every state? Any advice that you can give our folks if they want to kind of launch or start to think about doing what you did?
Yeah, I think, from a national standpoint, there's an Office of Clinical Affairs at the Blue Cross Association, and you mentioned a couple of those folks, particularly Alan Korn, who's the Chief Medical Officer up there. From a statewide or from a plan perspective, I think the Chief Medical Officer is a great place to go. They generally have, an understanding of what goes on in their network, as well as some of their national business. They have the state-to-state contacts, and that's a pretty innovative group these days. They also get together. We get together at a minimum quarterly, face-to-face, to talk about issues and opportunities. So those would be sort of the two places I would go.
Great. We will close on time, but I did want to I want to come back to each one of our speakers that are on the line right now and address this issue of the performance gap. I think that there's universal appreciation by those that are clinicians that our state performance is really in the tank. We like to do much better. I like to describe that we have islands of excellence in a sea of risk, and that's why people come from all over the world to learn from our great doctors and our great nurses and our great hospitals. But our support systems, which are disproportionately administrator-led support systems, are maybe 15 to 20 years behind. And I think we're all in agreement that we have a lot to do to improve. As we move forward and prioritize what we are doing, we really believe that people like Reggie and others in the community need to be involved to reinforce and to really underscore the positive deviance of the great role models that are doing a great job, and that we really need a kind of a cross-functional group in local communities to really tackle some of these challenges. Any advice that you can give our audience, this is a mixed audience of suppliers, providers, and purchasers that are seeking some insights in partnering. We have QIO leaders who have a charge by the federal government to really get patients involved and get governance leaders involved in what they're doing. Any ideas, any tips or reactions that you all might have? I'll start with Frank Guilleteau. Frank, your perspective is from the impact calculators. Any advice?
Right. In establishing, as you say, a lot of this is available and will be made available through our website. So, as we kind of go through and continue to increase the knowledge that's available around the cost, we'll make sure to account and provide the input. And if anyone wants to collaborate with our initiative, please make sure to check our website at Safety Leaders and contact me, because I think as we add to the body of the knowledge, we can provide much clearer perspective and really start providing answers to organizations' specific needs, because there is a large number of organizations and there's large variability. And in our analysis, we've recognized that one size doesn't fit all. So understanding where they are in terms of their baseline performance and what they can accomplish based on best practices or new technologies, I think is critical in order for us to be able to articulate the message and then have the leadership fund these projects.
And I think both of us and our entire team would like to thank Steve Swenson, Mayo Clinic, and Mike Henderson from the Cleveland Clinic, Steve Grosspart from Catholic Healthcare Partners, and Frank Mazza and Charles Barnett and Doug Waite from Ascension, and Julie Morath from Vanderbilt. We've got such an incredible world-class team working on these impact calculators and models as they go through. I'd like to turn to Carlos and again recognize our conflict of interest with Carefusion as a funder of Chasing Zero and some of the modeling that we've done. But Carlos, we'd like your reaction, just as your send-off on comments, advice, tips, any thoughts that you might have to this mixed audience.
Sure. Again, to echo what I've said twice now, this is a tremendous opportunity for all of us in healthcare. The industry is undergoing tremendous change, and a lot of that change is predicated on the fact that at the current fiscal trajectory in the United States, it is unsustainable. So we need to find the best way to continue to deliver the best, the safest care to our patients, growing numbers of patients, higher levels of utilization, while also being good fiscal stewards of not just taxpayer money, but the money that is part of the American economy that goes to fund healthcare as an industry. I think the concept of partnership between the patient, the providers, the payers, and the vendors who provide the products that are part of healthcare is key. We all have to work together to make sure that we deliver the best and the safest care to patients without going broke in the process, and that's going to happen when we all work together.
Thanks so much. And Gladstone, you see the view from so many different directions, being a surgeon, urologist, an oncologist in the area of urology, and then pain and anesthesia. Are there common denominators that we can think about, because you've seen it from these different directions, as now one of our world-class leaders who's going to work on the safe practices for pain management for NQF?
Yes, I mean, I think, you know, we all do things differently, and we all do things the way that we were trained, and we all think that we are right. I think we just need to adopt the strategies of progressive organizations and listen to our front care providers, our consumers, our caregivers, and then come up with some standardized processes to make care safer.
This ends our webinar. We've gone a little longer, but it was worth it, and we just thank everybody for their attendance, and yes, it will be recorded and transcribed.